Okay, hi everyone. Welcome to second lecture for the week. So in this lecture, we're going to talk about Canadian healthcare systems. Brief overview, we're going to look at healthcare systems, human resources, as well as health system outcomes. So we're going to take a look at the Canadian healthcare system, do some comparisons to some other countries, explore human health resources and other issues related to human health resources, and then also, again, look at some outcomes. So before we kind of jump into where we are today, I'll just do a really brief overview of the history of Canadian healthcare, how we've gotten to where we are. If it's something you're interested in, I can recommend some of the resources for you, but just really briefly to make sure we're all on the same page, I'll just highlight a few of these timeline pieces. So first Department of Health started in 1919, Royal Commission on Health Insurance, 1921. And then where things start to really set the stage for where we are today, in 1947, Tommy Douglas, who was the Premier of Saskatchewan, introduced universal public hospital insurance in Saskatchewan. And before that, there was no universal health coverage in Canada. In 1957, the Hospital Insurance and Diagnostic Services Act was passed. And where it starts to get kind of interesting here is in 1960, the CMA, so the Canadian Medical Association, actually openly opposed the provision of publicly funded healthcare. In 1962, Saskatchewan was actually the first to introduce public healthcare program, including one that paid for all people who lived in Saskatchewan to be able to access physician services. So first started off in the hospital and then later moved out of the hospital to all physician services. And in 1962, the physicians in Saskatchewan actually did strike in opposition to this public coverage. So it hasn't always been peachy between healthcare providers, especially people getting paid by the public system, and public interests related to universal health coverage. So this is a picture of Tommy Douglas saying, "Courage, my friends, 'tis not too late to build a better world." So really someone who set the stage for our modern Canadian universal healthcare system. Continuing on, so in 1966, they started with a 50-50 cost sharing program between the provincial and territorial and federal governments. So because another piece of this is who pays for it. Is it the provincial governments? Is it the federal governments? And that's something we'll talk about a little bit more now. In 1977, the federal government retracts 50-50 cost sharing and moves to actually block the funding. But in 1984, Canada Health Act is passed. So that really did set in stone the universal health coverage that we have today. But, even with discussions now with attacks on universal health coverage, it has always been a bit of a contentious topic. In 1990s, there was a lot of regionalization that started to happen. So provinces trying to figure out how they were going to essentially deliver these services that they were now mandated to deliver to the populations. In Alberta in 2000, they actually passed legislation to allow for private hospitals. Skip over a few of these, but basically then we're seeing in the early 2000s that we're realizing that primary healthcare has been underemphasized, and there's a realization that overall, we're moving more and more into sick care rather than preventative care. So, and obviously providing care in hospital settings is much more expensive than care in the community that is more preventative and less specialized. So in the early 2000s, there was some large investments made to begin to figure out if we could do a better job of primary health care. So those came in the form of the first ministers' meeting and creation of the Health Accord. In 2004, the Public Health Agency of Canada was created, and that was partially in response to SARS that came out, and it became a legal entity in 2006. I added to here too as well in 2008 to 2015 was the Truth and Reconciliation Commission of Canada, which, although perhaps not only directed at healthcare, it was an examination into the history of residential schools in Canada and the lasting impacts on the mental health and physical health of Indigenous peoples of Canada. Of course, in 2020, we had a global pandemic. I couldn't leave that off the list. And now coming into today, where we'll spend the rest of our time talking about universal healthcare, what it means to have universal healthcare, and where we're going from here is in 2022, we actually got national dental coverage for kids under the age of 12 for certain families with certain incomes, so with lower incomes. So we're going to talk about what it means to have universal health coverage, where we are now and where we're going. But obviously this isn't something that is necessarily static, and there's a lot of work that still needs to be done to figure out how we can deliver high quality universal healthcare across the country. So now we're at a stage where federal government transfers the provinces, and the provinces are then responsible for delivering service that follows the principles of public administration, comprehensiveness, universality, portability, and accessibility. And one thing that is interesting that's been happening recently on the last federal budget is the federal government, you could say, giving provinces a slap on the wrist for delivering private services that patients are then paying out of pocket for. So services that are meant to be publicly administered, that provinces have allowed private companies to begin to deliver and allow patients to pay for and have to pay for, they're actually being subtracted out of their budgets. So the federal government is sending a pretty clear message that they are not willing to bend on these principles, and those federal transfers are dependent on provinces' compliance with these principles. Healthcare for Indigenous peoples, so First Nations, Inuit, and Métis. There's some sharing, so federal, provincial, and territorial levels share some jurisdiction, but Indigenous Services Canada is a primary actor there. So as I said before, so the federal government, outside of some involvement in the health of Indigenous peoples, as well as the active members of the military, really hands over control of health service delivery to the provinces. So in terms of health service planning, the provinces are the biggest player regarding health policy. So systems, that's why in some ways we have so much variation in terms of province health systems, because it really is determined by provincial leadership how that's going to be delivered to the population within those general principles that we talked about. So the health insurance they're required to cover for everyone who lives in the province is hospital and physician services. And what's not covered under the universal health insurance is things like some prescription drugs, dental care, although that's not completely black and white and it's slowly changing. Things like long-term care and mental health care. So not to say that none of these are covered at all, but whereas if you walk into a hospital, I mean, all of us know this, and you have a broken leg, you shouldn't get paid, or you shouldn't have to pay for that. So whereas some of these other services that are more kind of deemed to be extra aren't necessarily covered unless you have private health insurance, which is something that's being looked at and is probably something that's going to be in the debate kind of over the next 10, 20 years as we look forward into where we want a health system to go. So the overall responsibility for funding allocations is really determined by the province and then the region. So how they choose to spend the money that they are given by the federal government is regionally determined. So another piece that the provincial and territorial governments do is negotiate physician fee schedules, which are obviously a major cost to the health system, and are one method of incentivization throughout the healthcare system. So there has been some changes related to fee-for-service physician compensation that's been looked at, and there's been some changes recently. So again, some of these things that we haven't seen a lot of change in, they're being re-examined as we figure out the best way forward, both from primary care and then the overall health system. So provincial and territorial governments do set strategic directions and priorities, and so they also regulate in the range of legislation to address the different components of healthcare, including the Health Professions Act. So that's regionally determined or provincially determined. There's a lot of that legislation. So for instance, scope of practice, that's why some scopes of practice are different in different provinces for, say, an RN versus like psychiatric nurses or nurse practitioners. The overall, how it's organized, how the how care is structured. And overall, we have been seeing spending increase in the provinces, driven by a few factors, including aging population, increasing complexity of drug costs, increasing complexity of new technologies wanting to be used or utilized in the system. So, and generally it can be quite a contentious topic in the public policy realm. So spending and cost do tend to be high on the list of topics that people want to talk about when they're talking about how care is structured. Municipal governments do have some role. So historically, they really did have much more of a jurisdiction in healthcare up until about the 1970s, in which case then it started to regionalize more, where larger organizations were able to be more efficient. So we saw, like in BC, we have the 5 main health authorities. But of course, they still have an influence on public and environmental health. So municipal governments have impacts on social determinants, such as providing green space, clean water, public programming to residents. So maybe not quite as directly involved in healthcare policy, but they do have a role. And obviously that's, if anyone is a Parks and Rec fan, that's, yeah. Okay. Regionalization. So regional health boards are responsible for hospital and community care. So if you're located in the interior, then that would be Interior Health. But then we also have Fraser Health, Island Health, Vancouver Coastal Health, and Northern Health. So those are the bodies that are really responsible for driving community and hospital care. So decision making is more localized, but it's not perfect. So there are opportunities for more horizontal and vertical integration. The benefit of regionalization rather than municipal governments only handling healthcare is that there's some level of economy at scale. So things can be more efficient, maybe not, it depends. But when there's larger, you're looking after larger population, things can be more efficient because they can be managed at scale. And that's the idea, to have greater efficiency in health systems, but without losing some of that local knowledge and local decision-making power and knowledge of the local communities that's necessary to do a good job of offering services. So policies and structures continue to evolve and around centralized versus decentralized decision-making. So it is that balance of who's the right people to be making those decisions, how much centralization is helpful versus once you decentralize too much, then you perhaps lose some of the personalization, for lack of a better word, that is necessary for these different regions. So it's a balance. So the organization of healthcare services in Canada. So as I was kind of saying in the history piece, primary healthcare has historically been somewhat underemphasized. So there's definitely a move towards emphasizing more primary healthcare. So with the goal of improving population health across the continuum. So really that population, macro level, community, meso, and then personal orientated micro, with the real goal of primary healthcare being a driver of comprehensive, coordinated, and integrated care. And then again, we are starting to see more of a desire to integrate health and social care, whereas perhaps historically those two pieces have been siloed. The idea is that primary healthcare would be the first point of contact and would have more of a focus on prevention and health promotion rather than like the sick care that we've been seeing historically, where it's more focused on those downstream health consequences. We've seen a push towards the patient medical home, especially that's a little bit more centered around family physicians, but overall, in the overarching primary healthcare lens, it's an important piece. So the desire to improve care coordination and improve patient-centered care. So this is the kind of graphic that they use to talk about a patient medical home, patient-centered care. So the overall goal is to have that whole person care. They have contact, so they have timely access to people that know them. So the idea is to have attachment between family doctors and patients, coordination of care, that care is well coordinated, that people aren't falling through the cracks. Care is continuous. So when at all possible, people can be cared by the same people, that again, there's no those gaps in handoffs that we often see. and comprehensive. So they have access to all the care that they need. And one piece of that that's been definitely emphasized is interdisciplinary teams in primary healthcare. And that's something I've worked on a little bit. So, but those don't come without challenges. There are some challenges in implementation, especially when primary healthcare has been delivered in one way for the most part for so long. There's some growing pains in terms of figuring out the best way to implement these care teams or patient medical homes, especially when there's sometimes a bit of resistance to change, let's say. So some enablers that we look at are the fact that we have, this technology that can enable, or it can also, block patient-centered care, block the ability of the patient medical home, having education and training and research into how the importance of primary care and the importance of these principles of coordination and comprehensiveness, et cetera, evaluation and figuring out how we can do things better in the primary care setting, and then also having the internal versus external supports. So this is definitely an area that has much work to be done, and it's an area of current change that we're seeing a lot of development in. So some primary healthcare principles. So we talk about accessibility, so having universal access, the foundation of national healthcare systems, and the first point of contact in the continuum of care. We want public participation, so for full participation of individuals, families, and communities, and in the planning, implementation, and evaluation. So again, with that emphasis on patient-centered care and family-centered care, what do the users want? What do the people who are using the system want and need? Care that's sustainable and has self-management and self-determination. So there's that piece of local decision-making and health promotion. So education and services for disease and injury prevention and health promotion, again, trying to move more upstream to preventative care rather than later stage care that happens in the hospital that's more expensive and not as good for the system, I guess. Skills and technology. So we want evidence-informed care adapted to context and culture. So again, some of that piece of regionalization of a complete lack of regionalization might make for an efficient system, but it might not be locally informed, and it might not be a good fit for the people that are using it. So figuring out how technology can enable versus disable the integration that we're looking for in primary healthcare, and incorporating research, so incorporating that evidence base into decision making, and of course the intersectoral cooperation. So really addressing the social determinants of health, including social policy, including interprofessional and intersectoral collaboration is really important, because as we've seen, siloing care doesn't really work, because we're working with whole people, not body parts. So keep in mind. Primary health care. So generally it's kind of referred to more by the care of the family physician, but as we're seeing nurse practitioners become more prevalent in the community, and as I said, we're seeing more of a move into interdisciplinary team-based care, kind of moving away from that traditional definition of the family doctor as the only provider of primary care. And so it's been a major focus of reform in Canada over the last 15 years. But we are still seeing challenges in implementing interdisciplinary team-based care, such as things like incentive structure, what's the right team composition, who decides what the team composition is, management. So again, if we don't incentivize people well, then these things probably won't happen if we don't create structures that support rather than deter things like interdisciplinary team-based care. Just a note about organization of healthcare services. This is probably something that's familiar for most people. So where we have the primary, the prevention, the out of hospital care, community care, then you move into the secondary care, which is more home care, specialists, potentially long-term care. Tertiary care is somewhere like a center like Kelowna General Hospital, where you do have more specialized services. It's getting more specialized all the time, but maybe not the highest level of specialization within a region. So for instance, within the province. And then you have the quaternary care, which is the highest level of specialization. So something like, the St. Paul's Cardiology ward where they do the heart transplants, and that's the only place to do them in the province, right? So that is that highest level of specialization care. So I guess the idea is that we're trying to move things further upstream to primary care, so they're caught and we're dealing with a more preventative healthcare system rather than the sick care system that we're, for the most part, currently dealing with. Human healthcare resources is a major piece of this puzzle, so it's highly complex. There's lots of changes that are driving it, so changes in education of providers, workforce. There's a lot of variety in healthcare providers. Some are regulated, some are not. So if we think about people like, care aides, it requires education, but it's technically unregulated, versus nurses where, the education is longer. We have regulations, we have unions. So there's a lot of pieces of that puzzle of that human healthcare resources that are required to get the right balance. Some require lots of training, examinations, licensure. So the planning of this takes a lot of time. It's not something that can be planned for in the more short term. It has to be something that is planned for more in the long term. And it does differ across provinces. So as we said, there's it's provincially determined what things like scope of practice and whatnot are allowed. So that's something to keep in mind, that one thing that might work for one province might not work here. A note about health system outcomes. So in 2011, it started off as the triple aim, which was quality of care, access to care, and cost. And since then, the quadruple aim, it's actually been expanded to the quadruple aim, which is focused on patient experience, population health, reducing costs, but then also this fourth piece of care team well-being. So where we're talking about the human healthcare resources, accounting for quality of work, quality of life in the care team, which I think probably most of us know is important to overall functioning of a quality healthcare system. So patient experience, quality and satisfaction, provider experience, health of populations, and then also the cost. So we really want to, there's a strong focus on integrating the health system and integrating care at all levels to create patient-centered, intersectoral collaboration, information sharing. So a lot of these pieces are in place, but it's a little bit figuring out how the best way to go forward is with the changes in healthcare policy, healthcare structure, technology. It's constantly changing. This is a few ideas. This is a great book to improve healthcare. Definitely not on the required list, but definitely recommend it. So the big idea is, number one, to return to relationships. So ensure that Canadians have relationship-based primary care. So that will help with, care coordination, continuity, comprehensiveness, potentially. So that understanding that there's some level of relationship, especially in primary care, rather than the one-offs and the which work too, but in some situations, but especially when we're talking about more complex patients with complex care needs, having that continuous relationship with a primary healthcare provider is really essential. Big idea number two is a nation with a drug problem. So bringing prescription drugs under Medicare, and Dr. Michael Law will be talking about that to us tomorrow. That's a big piece of his work, because I think we all have seen patients not be able to afford medicines, and the impact that can have on their overall health outcomes and the cost to the health system downstream if they're not able to take really important medications, potentially life-saving medications. Big idea number three is don't do something, just stand there. So the reduction of unnecessary tests and interventions. So this is a complicated thing, complicated piece, but there is a lot of waste in the healthcare system. So making sure the right people get the right interventions at the right time is really essential. Doing more with less, so recognizing that healthcare delivery to reduce wait times and improve quality, reorganize healthcare to delivery. So there's things like centralized waiting lists that have begun to be implemented and begun to be tested. Essentially just having more of a planned structure in terms of figuring out how we can do a better job of reducing waiting times. And I think throughout the course and throughout the readings, there's and even in the news, we'll probably see some stories in one of your assignments that there's a push towards this dual system of splitting into private and public. And generally speaking, and you'll see throughout some of the articles that we read, the evidence does not point towards that being the answer towards reducing wait times. But we'll talk more about that as the week goes on. Big idea number 5 is basic income for basic health. Definitely another potentially controversial subject, but I think this one gets to the idea that health is determined by these social determinants of health, including income, including like things like access to medicines, including the ability to buy good food, have the ability to exercise, all these pieces. So the idea that social programming is essential to health and healthcare. And then the anatomy of change scale successful solutions across the country. So there's a lot of pilot testing done in Canada, and there's from what I've heard or seen, I guess, is there's a lot of good pilots that kind of don't go anywhere because we don't do a great job of scaling. And I think one of those pieces that's challenging is the provincial, because provinces are completely responsible for their provision of health services delivery. Sometimes we see great solutions happen in one province and then they're never replicated. So there's a push towards trying to learn from each province, and even though each is different and has different contexts, that some solutions can be scaled across the country. So trying to not reinvent the wheel as an idea. And those are references. So those are just a few ideas of understanding kind of the Canadian healthcare system and kind of where we are, how we've gotten to where we are now. And if you have any questions about any of this content, then please write them down and feel free. We'll have a little bit of time as a group to discuss. And there's a lot of ideas in here that we'll explore more as the week goes on. Thanks so much.